Hi, everyone, and welcome to our grand rounds. I'm Professor Lara Ray in the psychology department and also in the psychiatry department here at UCLA. I am delighted to welcome you all and to welcome Dr. Lorenzo Leggio, our presenter today. We are very fortunate to have Dr. Leggio with us. And I will keep my introduction brief. We all know about Dr. Leggio and his seminal contributions to addiction science. What you might not know is that Dr. Leggio is also a talented clinician and a physician and clinical director at the NIDA Intramural Research Program. So I encourage all of us who aspire to really make a contribution to patient care, to our science, to listen to Dr. Leggio, not only for scientific contributions, but also for his thinking and how he really conceptualizes addiction, not only from a scientific perspective, but also as a physician scientist. So I think it's very inspiring to see Dr. Leggio. I've had the pleasure of knowing him since he first started his career in the US at Brown University. We overlapped several years back, and he has continued to soar into the field and take leadership. But one thing that I know from the very, very beginning that Dr. Leggio maintains is true patient-centered, patient-oriented research. So please join me in welcoming Dr. Leggio, and I'm looking forward to learning from him as I always do. Thank you, Dr. Leggio.
Okay. Oh, so sorry. I know when we spoke about the seminar, I was asked, do you want to do a Zoom practice? And you say, no, of course we don't need a Zoom practice, but something always goes wrong after many years of being on Zoom, right? Anyway, sorry for the delay. I'm so delighted to be here with all of you today. I wish I could be there in person, to be very honest. Because of family reasons, I could not really travel this week. So I'm very grateful for the opportunity to be with all of you virtually. I want to thank all of you at UCLA, in particular, Dr. Jonathan Heltz for inviting me. And also, thank you so much, Dr. Ray, for your very kind and very generous introduction. When Dr. Heltz reached out to me, he was in particularly asking me to focus on what is happening with GLP-1 and alcohol and addiction in general right now. So what I try to do is to give you a kind of a broader perspective about the state of the art, if you will, in the addiction field. And then I will focus on one example, which is our and other people's ongoing work on GLP-1 and addiction. And starting really from the broader perspective, as we all know, we are actually in the middle still of a very important public health and medical crisis, if you will, which is what we also refer as the death of despair, where basically in the United States in particular, there is this very concerning number increase in the death driven primarily by mental health disorders such as suicide, drugs, addicted drugs, and alcohol-related death, and also some of the medical consequences related to addiction, such as alcohol-associated liver disease, and much more. And today, what I will do in speaking about addictions, I will focus on alcohol use disorder. And because of time, I will not really talk about other substance use disorder, but I think it's fair to state that many of the concepts that we are going to cover today also are important in the addiction field in general. And of course, we are in the middle of an opioid pandemic as well. And when we'll talk, for example, about GLP-1, although I will focus on alcohol use disorder, there is also increasing a very exciting progress in how these targets may be important for opioid use disorder as well. But focusing on alcohol use disorder, I know this is something not new to any of you in the audience, but just as a reminder that we think about alcohol use disorder as a spectrum that it can be mild, moderate, or severe. It can cause lasting change in the brain that make patients vulnerable to relapse. And in thinking about alcohol use disorder and problematic alcohol use in general, we are talking about really a leading cause of mortality and morbidity in the States and worldwide. Alcohol is responsible for thousands and millions of emergency department visits. For those of you who are clinicians who work in the emergency room, you all know that when you are on the shift on the emergency room, people with alcohol use disorder are some of the typical unfortunate patients you see, in particular on the weekends. Alcohol is a leading cause of death, as we were just saying before, responsible both for acute and the chronic alcohol-related death. And alcohol is actually responsible for a economic burden, which is really gigantic in the United States. These snapshots come from the AAA website, and look at the data from 2010. Alcohol misuse was responsible for a cost equivalent to $249 billion. As we all know in this audience today, one of the biggest problems with alcohol and substance use disorder is the stigma around this medical disorder. It's actually the fact that we don't see as a society alcohol and the drug problems as medical disorders, but rather we see those as bad behaviors, etc. And this is actually one of the reasons why in the field there's been a lot of emphasis in trying to define addiction as a brain disease. This goes back to the 90s when Alan Leshner published the seminal Addiction is a Brain Disease article in Science. Dr. Volkow, Dr. Koob, and Dr. McLean have been re-emphasizing this concept. And I myself was part of a group of people who wrote this review in 2021, again emphasizing that addiction is a brain disease. And although it's still controversial somehow, I think the reality is that we should, I believe, think about addiction as a medical brain disease. And the fact that we see addiction as a brain disease does not negate by any means the role of the environment around this medical problem. I would say that nobody will argue or will argue that the other diseases such as diabetes, obesity, hypertension do have an important environmental factor. You know, what we eat, how we live, exercise, etc. But nonetheless, nobody will question that the diabetes, hypertension, and obesity are medical problems. And with addiction, we are still in this sort of a society fight where we keep on pushing the idea that these are medical problems. And this is important because unless we do recognize alcohol use disorder and substance use disorder as medical problems, we will never be able to provide dignity to our patients, which also means that this will be important obstacles for us to push the envelope, the agenda in developing new treatments for addiction. Also, it's very important to emphasize that when you think about addiction as a brain disease, these are highly translational value because, as a matter of fact, the gain in knowledge in the past decades related to addiction has been instrumental in helping the field to identify new targets and develop new treatments for alcohol and substance use disorder. And also, this has been instrumental to help all of us to understand that when we think about addiction, including alcohol use disorder, we can't think just about one single phenotype. We just cannot think that with one single medication or treatment, we will be able to treat every single patient. But the point I'm making here as part of my introduction is the concept that the complexity of addiction and the complexity of the brain-centered neurocircuitry that underline the development and maintenance of addiction also reflects the complexity and the heterogeneity of our patients. And for those who are interested in reading more about this, I will actually refer to a very recent review from Dr. Laura Ray with Dr. Nito and Dr. Erica Grodin at UCLA, and where actually they very nicely disentangle how the complexity of the neuroscience knowledge we have may lead to the complexity of the different phenotypes of our patients. And this, in turn, is critical in developing new medications and in trying to develop precision-based and oriented medication. So I will definitely encourage all of you to read this spectacular neuroscience framed recent review from the UCLA team from Dr. Ray. Now, the knowledge in neuroscience has been already instrumental in leading the development of new treatments for addiction, including alcohol use disorder. And in fact, we do have 3 FDA-approved medications for alcohol use disorder, which are naltrexone, acamprosate, and disulfiram. We also have what I will call the second wave of development in the past 20 years-ish, which has been basically the development of or repurposing of medications already in the market that have been repurposed for addiction, including for alcohol use disorder. And examples of this second wave include the 2 medications in particular, topiramate and gabapentin, which are not approved by the FDA for alcohol use disorder, but they have been endorsed by, for example, the American Psychiatric Association as a potential second-line treatments for patients with alcohol use disorder. And there are many other examples of second wave medications that have been tested in this context. And finally, today, I will focus more on the third wave, which in particular, since I moved to NIH, has been my main focus in looking at novel ways to understand better mechanisms related to addiction, including alcohol use disorder. And by doing so, try to unfold the complexity of a physiological mechanism related to addiction, and then use this information toward hopefully the development of new treatments for patients with alcohol use disorder. And in my program, what the framework of our program, I would say, is based on actually quite simple principle. We believe that addiction is a brain disease. But we also believe, and in part this comes from, I believe, in my background of being an internal medicine physician by training, that we cannot really study the brain in isolation without considering the rest of the body. And so because of that, I've been actually quite interested early on in my career on how the brain works and communicate with the rest of the body, and how this periphery brain periphery connections may help us to better understand addiction. And this has been the framework why we have been looking, for example, at neuroendocrine pathways related to the heart-brain axis. For example, right now we are studying a specific heart-brain neuroendocrine axis, which is aldosterone. And as a consequence, we are studying medications like spironolactone in the context of alcohol and opioid disorder. And on a similar way, we have been interested in the microbiome gut-liver-brain axis. And again, we have been focusing on neuroendocrine pathways related to the gut-liver-brain axis to pose the question how these pathways may help us to better understand addiction and develop a new treatment. And in my career, first in Italy, and then when I was at Brown and now at NIH, we have been looking at multiple of these neuroendocrine pathways, including leptin, insulin, ghrelin. And actually, since 2015, we have been interested in GLP-1. But before I talk about GLP-1, I also want to deep dive a little more on what has been our rationale to study the gut-liver-brain axis. And part of our rationale really starts from the idea that we know, and it's well known in the literature, both the preclinical and clinical, that the gut-liver-brain axis plays an important role in appetite, food intake, and from a pathological standpoint in obesity. But much less has been understood beyond obesity whether this gut-liver-brain axis may also play a role in addiction. And so our framework is based on the idea that there is, in fact, an important overlap between food-seeking behavior up to the phenotype that we call obesity and alcohol and drug-seeking behavior. For example, from a neurobiological standpoint, we do know that the neurocircuitry that regulate addiction, including alcohol addiction, do overlap with the neurocircuitry that regulate pathological overeating. That actually is a very nice review written by Kathy Moore with Valentina Sabino, George Kube, and Pietro Cotone, where they really make this a parallel at the neuroscience level between the analogies and the parallel between brain neurocircuitry related to pathological overeating and brain circuitry related to alcohol and drug addiction. But moving from neuroscience to humans, we also have evidence from human studies. That's just an example, many examples I could make of the work done by Dr. Volker and colleagues, where they show, again, in humans, the similarities between the brain of a patient with addiction, in this case, patients with cocaine use disorder, and patients with obesity. Now, this is an example also of neuroimaging experimental medicine kind of work. But we also know from clinical practice that when we use the medications to treat our patients for addiction, these medications often have effects on appetite and weight loss. I mean, among many other examples, I think an obvious example is topiramate, which actually is approved as a combo for weight loss. And topiramate is actually as I was mentioned before, a medication not approved by the FDA for alcohol use disorder, but with very strong evidence of efficacy and has been endorsed by the APA. But besides topiramate, we have many other examples of medications that are used in clinical practice for addiction that also have effects on appetite and weight. So kind of to recap, basically, we have evidence from basic neuroscience, from human experimental medicine, and from clinical practice that there is, in fact, an overlap between obesity and addictive disorders. And this concept has been the reason why we have been focusing on neuroendocrine gut-liver-brain axis pathway. And the way how we work and we frame our work in our program is really multidisciplinary. So our lab is located in Baltimore at the NIDA Intramural program. We are a joint lab funded by NIDA and NIAAA. And sometimes when I describe my work these days with my PI hat, I really describe my role as a sort of an MPI using the grant lingo kind of work, because a lot of my work these days is done in collaboration with other PIs. And we work together as a multiple PI team, so kind of a team of teams, to address a scientific question, in this case related to development of new treatments, looking at the neuroendocrine pathway from different angles, so starting from a basic science, moving to early phase human studies, up to clinical trials, and up to T4 community population level translation to population. So today, as I will tell you our ongoing story on the GLP-1, I think I will also indirectly provide you an example of this multiple PI framework, how I work in the intramural program of NIH. And specific to the GLP-1 work, I want to mention a few of the key collaborators that have been instrumental as co-PIs in the work I'm going to present. So at the basic science level, we have been collaborating with Leandro Vendruscolo, who is a tenure track investigator at NIDA, and also with George Kube, that many of you know as the NIAAA director, but George is also a PI in the NIDA intramural program. We also have been working with Marisa Roberto at Scripps and with Igor Spielberman at UCLA. And then moving from basic science to early phase, this is actually the work primarily driven by my lab. In particular, Mehdi Farokina is a staff scientist in my lab who has been playing an instrumental role. And moving to more patient-oriented clinical trials, we are currently collaborating with Carl Simmons at Oklahoma State University. And finally, at the population level, in the past years, we have been expanding our agenda by looking at electronic medical record-based pharmacoepidemiology, and this work has been done with Vanessa Pazos at the Kaiser Permanente Research and at the Yale in collaboration with the VA, in particular with Chris Ranch. So this has been our main collaborator for our GLP-1 work. Now, many of you, I'm sure you know, because GLP-1 is becoming such a hot topic nowadays, that this is a gut hormone primarily produced by the gut, of course, And it has a well-established role, the glucagon-like peptide 1, we go with GLP-1, in controlling glucose levels, and also in controlling gastric motility. And the knowledge of a GLP-1 as an important regulator of a glucose homeostasis has been the basis for the development of a GLP-1 receptor agonist as effective treatments for diabetes, specifically for type 2 diabetes. But GLP-1 is also a neuropeptide, and in fact has been shown that the GLP-1 is also secreted in small quantities in the nucleus tractus solitarius. And this has been leading to several lines of research that have been demonstrating the role of a GLP-1 in reducing appetite. The mechanisms are not necessarily fully understood in terms of peripheral versus central. Most likely, there is a combo effect of a peripheral GLP-1 signaling directed to the brain, but also GLP-1 centrally acting in regulating pathways and mechanisms related to appetite and food seeking. And as a matter of fact, this has been the basis for understanding the role of a GLP-1 receptor and GLP-1 receptor agonist in controlling appetite and food intake via several mechanisms of action, including satiety, reward processing, and also other mechanisms related to stress and extra hypothalamic stress-related pathway. And as we all know, also because of the popularity of these medications, the critical role of a GLP-1 in controlling not only glucose homeostasis, but also in control of food intake has been the foundation for the development of these medications, not only for diabetes, but also for obesity. And as a matter of fact, the two of these medications, liraglutide and semaglutide is the most popular. It goes with the brand name of Ozempic and Wegovy. They're both medications approved for weight loss, and actually maybe the most effective treatments we have for obesity right now, at least from a pharmacotherapy standpoint. Now, despite the popularity of these drugs in the past maybe 2-3 years, I hate to say that it's important to know that the research on the role of GLP-1 in addiction, it goes back many years ago when, in particular on the basic science level, people start to look at the potential effect of GLP-1 receptor agonists or analogs on addiction, including alcohol, opioid, nicotine, cocaine, and amphetamine. And what I'm going to do today, I will focus on some of our work specific on alcohol, but again, it's important to know that there is important, exciting research on drug addiction as well in the context of a GLP-1. And we have been posing the question regarding GLP-1 and alcohol from two kind of a complementary perspectives. One question has been how and if alcohol and alcohol dependence may affect the endogenous GLP-1 system. And I'm going to talk next about that. And then the second question has been whether the GLP-1 system may be a target for the development of new pharmacotherapies for alcohol use disorder. So starting with the first question, and I will do this very briefly because I think the second part is the most compelling for our patients from a translation standpoint. But starting with the first kind of a line of research in our lab, we have been showing, this is, for example, an example from a recent study we published 2 years ago, that alcohol administration acutely leads to a reduction in endogenous GLP-1 levels in the blood. And we have seen this regardless of whether we have been giving alcohol orally, as you can see here on panel A and B, or if we have been given alcohol IV, intravenous, bypassing the GI, the gastrointestinal tract. And also, we have seen that whether we give alcohol as a fixed dose or whether we have been giving alcohol as a variable dose. So the take-home message of this kind of a set of graphs with some variability, as you often see in peripheral hormones, is that when we give alcohol, there is an acute reduction in the GLP-1 levels. And by contrast, here on the right side, when we also look at the expression of the GLP-1 receptor in post-mortem brain samples from Australia, we did see that in some brain regions, which are important in the context of alcohol addiction, such as the hippocampus and the PFC, we did see that there was actually an upregulation of the GLP-1 receptor in people with alcohol use disorder compared to control. So it's kind of interesting that acutely in the periphery, alcohol is lowering GLP-1 levels, but chronically, at least centrally, we didn't have a blood from these post-mortem samples, unfortunately, but centrally, alcohol chronically is up-regulating the receptor. And we also see that there was in the same post-mortem sample, there were some correlations between the expression of the GLP-1 receptor and some clinical features such as the age of onset of alcohol drinking, cigarettes packed per years, and cigarette again packed per years, both in the hippocampus and PFC, prefrontal cortex. Now, of course, these studies are correlation in nature, so I'm not claiming any causation, but the overall take-home message from this work is that, in fact, it seems like there is an impairment, if you will, of the endogenous GLP-1 system in people with excessive alcohol use, such as people with alcohol use disorder. Also, we have been looking at the GLP-1 receptor from a genetic standpoint, in particular looking at some genetic variants that are possibly functional variants, meaning that these genetic variants seem to be related to a loss of function on the GLP-1 receptor. And what we have seen with these two studies, in the first study, we saw an association between the GLP-1, some genetic variants in the GLP-1 receptor, and a diagnosis of alcohol use disorder. Actually, this was our first ever GLP-1 paper we published in 2015. And then based on the results from this first study, which was led by Dr. Sushankova, who was a visiting fellow from Sweden, then we did a follow-up study in collaboration with Reza Momerman. In this follow-up study, we show again an association, in this case, between the same genetic variants in the GLP-1 receptor, a brain functional connectivity using fMRI. And this work was also done in collaboration with Dr. Erica Grodin when she was actually postdoc at the NAAA, pre-doc at AAA, and now Dr. Grodin is faculty with Dr. Ray at UCLA. And if we put this kind of work together, again, the main take-home message of our work looking at GLP-1 as the endogenous system is that overall, we see this consistent association between difference in the endogenous GLP-1 system and alcohol use disorder. This whole work is not, doesn't show causality by any means. All this work has been primarily in association kind of work. But we think it's important to put in perspective for the second part of the talk, which is about GLP-1 as a potential target for treatment. The reason why we think this work is important is because even if the field will demonstrate that the GLP-1 receptor agonists are effective in treating addiction, and I emphasize even if because we don't know yet, but even if that would be the case, it's impossible to believe, and this applies to any medication, applies to all patients we see and we treat, that this medication will work for every patient, which brings the big $1 million question about precision medicine. So the point I'm making here is that our effort to better understand the relationship between alcohol use disorder and the endogenous GLP-1 system is to actually put the basis to hopefully identify predictors of a medication response, based on the simple assumption that we know from history that even if we find a medication that works, this medication will not work for everybody. So it will be important at some point to understand who may be the responders or the non-responders to GLP-1 receptor agonist in the context of addiction, again, assuming if they work. So that's, of course, the question that is right now very high priority, definitely in our program, both in the addiction field and in general. Are these medications really working or at least promising in the context of addiction? Now, from a basic science standpoint, like I mentioned before, the work toward the hypothesis, if you will, that the GLP-1 receptor agonist may work for addiction, it goes back to more than 10 years ago. The first paper actually came from Sweden, from Dr. Elisabeth Jorlak's lab, where they show a potential role of exenatide, kind of the first prototype GLP-1 receptor agonist, in reducing alcohol drinking. And so to summarize, not just this first publication, but all the work done in the past 10-ish years, there has been a growing body of a preclinical literature in mice, rats, and non-human primates, consistently showing that the administration of a GLP-1 or of a GLP-1 receptor agonist leads to a reduction in alcohol condition place preference, CPP, which, as we know, is a proxy of alcohol reward, reduction in alcohol, self-administration of alcohol, and reduction in alcohol preference. Now, I get to say that while all this preclinical work has been very promising, the translation to humans is still missing. This is actually the only published RCT randomized clinical trial coming from Denmark, where they look at exenatide. And when you look at the a priori primary outcome, actually they didn't see a difference between the drug and placebo. There was an overall treatment effect, but no separation between the drug and placebo. And then they looked at a secondary a posteriori analysis by splitting the sample based on the BMI. And what they found was that, in fact, there was an effect of exenatide compared to placebo in reducing alcohol drinking, but only in those people with comorbid obesity. And the way how I see this data is kind of twofold. The part of me says, well, Lorenzo, you need to be very skeptical. This is an a posteriori secondary analysis, so it could be a false positive. And it's true that as a secondary analysis must be replicated. On the other side, I do believe these data are potentially very intriguing because they do bring the question whether this subgroup of patients, people with AUD and obesity, may be the responder to these medications. We don't know yet, but that's a very intriguing question. Also, this clinical trial was designed and developed many years ago when exenatide was still the main GLP-1 receptor agonist used in clinical practice. But since then, there has been a quite exciting development of a new GLP-1 receptor agonist, including, for example, dulaglutide, and more recently, liraglutide and semaglutide. And semaglutide is a one-week formulation, which is very important in terms of helping patients with adherence to the medication, because now they only need to take the medication once a week rather than, for example, twice a day for exenatide. And so our initial focus has been on liraglutide and semaglutide. Actually, in collaboration with Dr. Igor Spilberman and Dr. Vincent Marta at UCLA, Mehdi and I did a preclinical pilot work, which actually was led by Dr. Igor Spilberman at UCLA, in looking at both liraglutide and semaglutide in the context of male rats, Wistar rats, using an alcohol preference to battle-free choice. And this pilot study was a very instrumental. We were very grateful to our UCLA collaborators because in this study, we did see that both the semaglutide and liraglutide had an effect on alcohol drinking, but the effect seemed to be more specific for semaglutide. So then our next step was actually to follow up on this work in collaboration with Leandro Vendrusco and Marisa Roberto. This work was published last year, was led by Vicky Chang, Mehdi Farrokhani, and Sophia Kolm. And what we did was to expand this basic science work to both male and female rats, but also to add a mouse model of binge alcohol drinking. And what we found was that the semaglutide dose-dependent reduced alcohol binge drinking, both in male and female mice, so with no sex difference, and regardless of whether it was alcohol alone or alcohol combined with the sweet solution. We also see, as we expected, that the semaglutide, in addition to alcohol, also reduced water, saccharin, maltodextrin, and corn oil. So the effects were somehow non-specific, but there was no effect on the sedation. Also, there were no effects on blood alcohol concentration. So overall, we believe that except with the highest dose of semaglutide, these effects of the semaglutide were non-selective for alcohol, but they were not due to a non-specific sedative effect. Now, in addition to our mouse model, then we branch out to a rat model of alcohol dependence, which was developed many years ago by George Kuber when he was at Scripps. And this work was led by Claire Pines when she was a fellow with us. In this rat model of alcohol dependence, again, we see that semaglutide is a dose-dependent, reducing alcohol self-administration, both in the non-dependent rats and in the dependent rats. And again, with no sex difference. And finally, with Marisa Roberto, we also looked at from an electrophysiology standpoint, and we saw that the semaglutide increases the GABA transmission in the central nucleus of the amygdala and the infralimbic cortex neurons from alcohol-naive rats. But when we look at the alcohol-dependent rats, actually the effects were less clear, so suggesting that maybe semaglutide is somehow interfering with GABA signaling at the brain level. But I hate to say these electrophysiology data are very preliminary, so take it with a grain of salt. We were also happy to see that the independent from our group, another group in Sweden led by Elisabeth Gerlach, also found quite consistent with our data, and the paper was published a few weeks after our paper. So our paper, so the two stories went in parallel. That again, semaglutide reduces alcohol intake and relapse like drinking, again without sex difference. While we've been wrapping up this preclinical work, our next step has been to develop a clinical protocol. And we've been working very hard to develop a randomized clinical trial to really translate quickly this information from animal models to humans, to patients with alcohol use disorder. It was kind of interesting, and in my career, unprecedented, that while I'm working with my team in developing the protocol, the mass media literally exploded with the idea of anecdotal reports suggesting that the semaglutide may be a new treatment for alcohol use disorder. Now, patients speak with reporters and say, my doctor prescribed me semaglutide, Ozempic, Wegovy for weight loss or for diabetes, but I have less craving for alcohol. I have less craving for cigarettes. In addition to that, these drugs have been very popular. Of course, has been influential that many VIP people, influential people have been vocal and destigmatizing obesity in saying, I'm losing weight on this medication. This is wonderful. Science declared GLP-1 therapies like the 2023 Breakthrough of the Year discovery. And I hate to say anecdotally that to me, the most striking surprise in thinking how exciting is biomedical research right now on GLP-1 is above and beyond science that the South Park actually has a dedicated full special episode to semaglutide. And to me, that was like really wow, the wow factor. But leaving South Park alone and back to science, the momentum has been so high that the people, including our own group, have been really trying to maximize translation information as quickly as possible and better understand whether these medications may or may not be helpful to our patients with addiction, including alcohol use disorder. And as many of you know in the audience, running a clinical trial, it really takes a village, a lot of resources, and time, years. So what people, including my own team, we have done is while we are conducting a clinical trial, a randomized clinical trial, we and other team have been also trying to look at other ways to gain more information. For example, this Danish retrospective electronic medical record reported an association between being on GLP-1 receptor agonist and having a less risk of alcohol-related events, including death and alcohol-related morbidity. This was by Jesse Richards et al., a case, a series of patients treated with semaglutide for obesity and reporting less alcohol drinking. And there's two papers, one led by Christian Andersholt and one led by Warren Bickel. They have been looking at social media, very interesting approach, where they've been looking at the association between being on a GLP-1 and reporting less alcohol drinking using social media data, so tweets, Facebook posts, etc., etc. Now, in addition to this work, which is of course a association-based work, so it doesn't prove efficacy by any means, and there are many potential confounders of bias. An additional approach is to do pharmacoepidemiology, which is still close to the first paper I mentioned before, basically electronic medical record, but a retrospective chart. But with pharmacoepidemiology, what you do by using computational approaches, including a high dimension propensity score matching, you try to mimic, you do basically a clinical trial emulation by trying to mimic a randomized clinical trial by matching people who were prescribed with a medication, in this case, the GLP-1 receptor agonist, and people who were unexposed to that medication, but who were otherwise matching with the treated population. And I hope I'm making this clear, but happy to clarify more during the Q&A. And by using this approach, Dr. Rong Hu in Cleveland, in collaboration with Dr. Volkow, they just actually completed this very interesting pharmacoepidemiologic analysis using commercially available electronic medical records. And what they show here is an association between being prescribed with semaglutide and reduced incidence and recurrence of alcohol use disorder. In parallel to this work led by Dr. Xu and Dr. Volker and other collaborators, my own team has been also working, as I mentioned before, both with Kaiser Permanente and with the VA, using our collaborator Chris Wrench at Yale, in a very similar question, which is the pharmacoepidemiology. But in our case, we've been looking on pharmacoepidemiology with two additional angles, or three additional angles, if you will. And the data I'm going to show actually are unpublished data. We are writing the paper as we speak. We have been looking at different outcomes. Rather than going back to the previous slide, incidence or recurrence, we have been looking at the actual alcohol drinking using the AUDIT-C score. Number two, rather than looking only at semaglutide, in order to have a bigger power, we've been looking at all GLP-1 receptor agonists. And finally, in addition to GLP-1, we have been looking at an additional class of medication, which is the DPP-4. DPP-4 inhibitors are medications also approved for diabetes, but not for obesity. And this is a class of medication that whose mechanism of action is a little different. Basically, rather than acting on the receptor, so mimicking the hormone, what you do with the DPP-4, you are blocking the degradation of the enzyme in charge of degrading GLP-1. So by blocking DPP-4, you block the degradation of GLP-1. So you are boosting endogenous GLP-1 hormone itself. And so we did the study using the VA database. Because of time, I'm not going to the detail, but that's the national VA database. This is Christopher Wrench, our collaborator. And so we posed kind of three questions: GLP-1 receptor agonist versus unexposed people, DPP-4 versus unexposed people, and finally comparing GLP-1 to DPP-4 inhibitor. And what we found was actually a very robust effect of GLP-1 receptor agonist compared to unexposed in being associated with the decreased AUDIT-C score. And as you can see, the overall effect is actually mild, it's weak, if you will, but the effect of GLP-1 receptor agonist compared to unexposed people becomes much stronger when you actually stratify people based on diagnosis of alcohol use disorder and or based on the baseline AUDIT-C. So the effect is primarily driven by those people with higher AUDIT-C, so with actually higher severity of alcohol use disorder. By contrast, when we look at the DPP-4 inhibitors, we don't see any effect whatsoever. So unlike a GLP-1 receptor agonist, DPP-4 inhibitors were not associated with the reduction in alcohol drinking. And finally, when we compared the GLP-1 receptor to the DPP-4, we see that, as we expect at this point, even from a statistical standpoint, is that the GLP-1 receptor agonist is superior compared to DPP-4 in reducing alcohol drinking. So based on this result, then we decided, this is in a sort of something we do in our lab on a regular basis to do back and forth between basic, clinical, and then back to basic. We decided to go back to the mouse and rat model that I presented before. So that mouse model of a binge alcohol drinking and that rat model of alcohol-dependent self-administration. So that model for which we did see an effect of a semaglutide in reducing alcohol drinking. And we posed the question whether DPP-4s consistent with our human data were or were not effective in reducing alcohol drinking. And we were very happy to see that consistent with our human data, our mouse and rat data also negative. These are the data with linagliptin, which is a DPP-4 inhibitor. We don't see an effect of linagliptin reducing alcohol drinking in mice or rats. And then also we pose the question whether this is due because linagliptin doesn't go into the brain. So we also test another DPP-4 inhibitor, which is ormagliptin, which comes from Japan and actually does cross the blood-brain barrier. But again, we did see negative data consistently across mice and rats. So we were very, very happy to see the consistent negative data between mice, rats, and our pharmacoepic data. And what you see here is a sort of a control experiment where we see that both the linagliptin and ormagliptin are reducing glucose levels, and they're doing so also in the presence of alcohol. So here, basically, we want to have enough evidence of a true negative by showing target engagement. So to summarize, I hope I have convinced you that we have generated a significant amount of work between pharmacoepidemiology, rat models, and mouse models of the efficacy of a GLP-1 receptor agonist in addiction, in particular alcohol use disorder, but we are missing randomized clinical trials. In this commentary we published a few months ago, we do emphasize a lot the importance of now conducting randomized clinical trials to see whether, in fact, we can prove that these medications are or are not effective. So right now in our program, a NIDA and Tremor program in Baltimore, we are conducting an RCT with semaglutide. This study is not a two-site clinical trial, but it's harmonized with another clinical trial led by Kyle Simmons, Oklahoma State University. And also, we've been lucky now to create a sort of informal network of PIs work on the same theme, including Christian Hendershot at UNC. Christian just moved actually to California, Joe Shax in Colorado, and also with Anders Finger Jensen in Denmark. And so all these clinical trials are in fact ongoing, and we really hope that these clinical trials can be wrapped up in the near future to really give an answer to our field. And so to summarize, I hope I convince you that alcohol use disorder is a treatable brain medical disease. We do have effective treatments for our patients, but the number of treatments is very limited. And so there is really a need for ongoing efforts to develop new treatments for alcohol use disorder and addiction at large. The example I spoke today, GLP-1, is only one of many examples. And in case you are interested to know more about novel cutting-edge new approaches to treat the problematic alcohol use, I will refer to this very recent review that I was lucky enough to co-author together with three friends of mine, including Dr. Ray from UCLA and Kathy Wickwitz and Marcus Halleck. And with that, I want to thank all of our collaborators, my team both in the lab and in the branch, and finally our funding. We are funded both from NIDA and at AAA, and also through the clinical center. And I will take 30 more seconds to really do an advertisement, which is for those of you who are, for example, undergraduate or graduate, you may know that in the intramural program, in addition of doing research, we also do a lot of training and mentoring. And we have in particular a scientific director fellowship for diversity in research. So I really encourage everybody to look at the training opportunities we have in the intramural program. And with that, I want to thank you for having me today, and I look forward to your questions. Thank you so much, and I will stop sharing.
Thank you, Dr. Leggio, for a fantastic presentation. It's always inspiring to see the data coming together, but also, your interpretation and how you approach this, as I said in the beginning, from, patient-centered kind of orientation. So I really, really appreciate it. I wanted to start with a question. In the field of psychiatry and medicine in general, in the academic medicine, we tend to be more conservative, right? So, for instance, if you think about TMS, ketamine, other treatments, we continue to study, seek FDA approval, and in that process, a lot of community work gets ahead of the recommendations, and what we see is that folks will then set up ketamine clinics or TMS clinics and all these kind of applied practices that are pretty much ahead of the scientific recommendations. So what are your thoughts on folks who may be just running to give GLP-1 to folks, in addiction, because as you said in the beginning, the needs are so dire?
Yeah, thank you so much, Laura. It's a very complex question. I'm glad you are asking, because I myself, I don't think I have a straight, firm answer. I don't think I hold the truth about what is right or what is wrong. But I've been asked this question multiple times, and my feeling is that right now, I will feel uncomfortable to prescribe a GLP-1 to a patient with alcohol use disorder just because the evidence is really compelling at the basic science level, at the pharmacoepidemiology level, but we are really missing evidence from randomized clinical trials, which brings the dilemma whether we are pushing a medication without evidence of efficacy, almost like we have the ghost back to the pandemic about ivermectin, right? And this kind of popular drugs with no really evidence. But on the other side, there is also potential for regret and feeling guilty because if they do work, we are now preventing our patients from accessing these medications. My sense is actually, I try to be very pragmatic. I tell people when I ask, if you have someone who also has obesity or diabetes and they are on these medications and they see a reduction in alcohol drinking, that's actually just fantastic. At the end, and no matter how and if it's working, if people reduce drinking, that's wonderful. But if people don't have those conditions for which there is a formal FDA approval, my recommendation would be start first with an FDA-approved medication. It does, we know only 2% of patients with alcohol use disorder receive a prescription for. If that doesn't work, try with the second-line treatment. Could be topiramate, could be carbapenem, could be varenicline, or any of this medication with some evidence of efficacy. And if that really doesn't work, then I think physicians and patients should talk and have a serious discussion about risk and benefits. And so if it's the last resort to try, I think try something is better than not doing anything and letting the patient go back to their drinking without engaging to treatment. But I think I will mention one more thing. It's very important also to keep in mind safety. I think these medications seem to be very safe, but there is always the potential for some new onset that we don't know. For example, we are paying close attention to pancreatitis just because these medications may give a pancreatitis, and patients with alcohol disorder are higher risk of pancreatitis. So there is also a clinical judgment in whether this should be implemented sooner rather than later, if it makes sense. I hope that answers your question, Dr. Ray.
Wonderful. Thank you so much. That's very helpful. And I really appreciate your emphasis also on training opportunities at NIH. I was wondering if you would have a few words of wisdom to emerging physician scientists and thinking about your own trajectory in terms of how to continue to grow, as a physician engaged in addiction science.
Yeah, so you ask a question which is very close to my heart. And if you speak with Dr. Newman, the scientific director, and Dr. Volkow, my boss, our director, I talk about this topic every single day. I'm pretty much obsessed as an MD, PhD physician scientist with the fact that when you turn your neck at NIH and you look at NIDDK, NCI, you have many physician scientists working in the field, of cancer, diabetes, et cetera. In the addiction field, we have amazing non-MD clinical scientists, which are phenomenal, but we are really struggling to also have physician scientists. And that's, I think, a big problem we have, because I think diversity of background is very important. So to have a very healthy clinical program, you really want to have experimental scientists who do the basic science in humans. You want to have a clinical psychologist who bring a lot of knowledge and a clinical expertise, which is really unparalleled. And you also want to have a physician scientist who bring also the medical aspect, like the medical consequence, the heart, the liver, the immune system, et cetera. But right now we really have an unbalance. I don't have an easy solution, but what I see over and over, we have a rotation actually at NIDA, and also we have a rotation at AAA, and with my PI hat, I'm a joint in NIDA and AAA for resident and fellows. But what I see, I was the physician on call and seeing patients last week, and we had our resident on rotation in my program, and she was shadowing me. And we were talking about, she was asking me, should I consider physician scientist route? The reality is that when you start thinking about that as a resident of a fellow, it's already too late. almost I feel like the train left the station. And I think one important investment is at the medical school level. I think it's very important, both for doctors going to practice and for doctors who want to be physician scientists, to really have a revolution of the medical school curricula, to really try to have addiction as a key component of medical school. And as part of that curriculum, to make sure that also physicians know that there is an addiction physician scientist track to consider. But also for doctors in practice, because you could be a dermatologist, you could be any kind of doctor, but there's no question that you will be facing the problem of a patient of yours who has an alcohol problem. And then the question is whether you will not recognize the problem, or you put your head under the sand, or you take the lead and say, you have a medical problem, I cannot treat you because I don't have the right skill set, but this is a referral.
Thank you so much. That's a really fantastic answer. I wanted to follow up on that. I really appreciate that you mentioned some opportunities at NIH. And my experience has been maybe in part because UCLA is on the other coast and a little bit of a distance to the NIH kind of headquarters, so to speak, that folks often don't know enough about the great resources. So I was wondering if you could take an extra minute to tell us about ways in which trainees can get involved in the NIH research and clinical enterprise.
Absolutely. And I will say right away, my email is on the website. If you just Google my name, feel free, any trainee here on the audience, feel free to shoot me an email if you want to know more. But in brief, we have actually a very, very solid training program, multiple levels. We have a summership program. We have a post-bac program, which is a superb. It's very successful, where we bring people after graduation for 2 years. This is a 2-year full-time fellowship. They work with us full-time in a basic science lab, in a clinical lab, and then they move forward to either a PhD or an MD or MD PhD or a master level for the most part. And they really learn a lot. They publish papers, they learn the techniques, they learn the methodology, they learn the clinical research, and they are fully merged into the NIH system with a lot of resources available. And we have a postdoctoral fellowship program. This is also open to non-US citizens. So that will be similar to a T32, but we have the luxury to also bring people from overseas through a visa visiting program. And this is up to 5 years. Sometimes I will be very honest. The one concern people have is, well, I got to work with the PI in the intramural program, but they have no clue how to write grants. Well, actually, many of our postdocs, well, those postdocs who decide to go to academia, they all write a K-99. Right now, I have a postdoc who came from UNC. He's writing a K-99. Some of them go to pharma, some of them study in NIH in different capacities. But those who want to follow the PI track, we actually, as a PIs, we step in and work a lot together with other colleagues, including from academia, to develop a K-99. And I would say that actually, and Dr. Ray is in the NIDA Board of Scientific Council, so we have a peer review system to really evaluate the PIs. So one of the most important metrics of accountability, in addition to science, is mentoring. So if you come as a trainee to work at NIH, your PI is accountable to train and mentor you. So we take that very seriously.
Thank you so much. A couple of quick questions on the scientific side that came in through the chat. One is about maintaining the blind with the GLP-1 antagonist because of the weight loss that may become very obvious to the treating team. And the other question is about the literature beyond alcohol for GLP-1, including stimulants and perhaps opioids.
Yeah, so for the first question, I'm glad you're asking, Laura. So I hate to say there is a lot of variability. So if we look at the data in obesity, yes, the GLP-1s are very effective in obesity. There is no question. But when you look at the data from the main, clinical trials, it's not that everybody was reducing weight. Many people were losing weight and many more people in the semaglutide group compared to placebo, but not everybody. So there is a lot of variability in response. So in our ongoing clinical trial, we're still blind, of course, but I would say anecdotally that we do see some people who are clearly losing weight, and we suspect they are on medication. But it's not like a 50% of the people for which we see, okay, this 50% is on semaglutide, the other 50 is on placebo. It's really mixed. So we don't really, I don't think that the blind is really jeopardized. In a sense, in the naltrexone clinical trials, you know, we did see sometimes people with nausea, vomiting, but many of the people on naltrexone without those GI symptoms, right? So it's kind of very similar. And your second question, sorry, Laura, can you say again?
Yeah, it was about any data indicating the potential efficacy for drug use indications such as stimulant use disorder, opioid use disorder.
Oh, yeah, absolutely. Yeah, there are very compelling data as well. I mean, there is definitely a very wealthy body of preclinical literature in the on the preclinical side. For example, Paul Kenny work at Mount Sinai on GLP-1 and nicotine has been really illuminating. There is also some pharmacoepidemiology work from the same group in Cleveland in collaboration with Dr. Volkow on nicotine and on cannabis. On the clinical side, there are some initial pilot clinical trials from Texas showing the potential efficacy of a GLP-1 in nicotine. And that's particularly interesting because one idea, which clinically makes totally sense, is the idea of people who quit smoking and you put on GLP-1 in order to not only help them to maintain nicotine abstinence, but also to prevent weight gain due to smoking cessation. And Sue Grissom at Penn State, she just finished a opioid study. This was a semaglutide opioid study in a residential unit where they see that the semaglutide reduces craving using ecological momentary assessment. And now they're launching a larger clinical trial. And finally, I will mention, actually, we are collaborating with UMB for a potential cocaine GLP-1 as the clinical trial. So there is definitely a lot of efforts in the non-alcohol addiction arena as well.
Wonderful. Well, we're at noon here in California and 3 p.m. For you, Lorenzo. And so I really want to thank you for this fantastic lecture. I want to encourage all of our colleagues, my colleagues at UCLA, to use the recording and to discuss all this rich clinical material and presentation with your groups, and that of course, you know, Dr. Leggio is accessible via email if there are questions about following up on training opportunities. So with that, I want to thank you again for a phenomenal lecture and for really inspiring us all with your work.
Thanks so much for having me. It was really an honor. Thank you.